Thank you very much for attending our second installment of the micro-ultrasound Masterclass webinar series. Today's session, we're focusing on the flexibility and biopsy approach using ExactVu micro-ultrasound, and we're going to highlight both the transrectal and transperineal biopsy approach using ExactVu micro-ultrasound. Then we're going to touch on the additional applications for micro-ultrasound and conclude the webinar with a Q&A session. Your mics and your cameras will be turned off, so please use the chat or Q&A feature to submit your questions. And we're pleased to be joined by two distinguished urologists who bring a wealth of clinical and academic expertise in micro-ultrasound. Dr. Paul Dato is the director of the Prostate Cancer Center at Unio Specialty Care, a cancer center of excellence in the San Diego, California area. He is a Tulane trained physician and completed his urology residency at Oakland Naval Hospital, going on to serve 25 years in the U.S. Navy, retiring as a captain in 2005. He's joined private practice in California and has led clinical trials and now directs one of the region's top prostate cancer programs. We also have Dr. Xiaosong Meng. He's an assistant professor of urology at UT Southwestern Medical Center in Texas, where he joined the practice and faculty in 2021 following a urologic oncology fellowship. Holding both an MD and PhD in cell and molecular biology from NYU, Dr. Meng focuses his research on clinical practice in the diagnostics and treatment of prostate, kidney, testicular, and bladder cancer. We're grateful to have both of them here today, and I'm going to turn the mic over to Dr. Dato, and he'll get us started by talking about transrectal biopsy for prostate cancer using micro-ultrasound. So Dr. Dato, go ahead and take it away.
Great. Good morning. Thank you, Corey. Nice to be with you all today. I want to thank Exact Imaging for the opportunity to present this information today. Corey, let's move on. I think next slides. And let's go. Okay, great. So transrectal approach to the performing biopsy is probably the most familiar and the most commonly performed prostate biopsy technique throughout the world. It's a technique that provides really excellent access to the prostate because of its proximity to the rectal wall, so you don't have to go too far to get to it. It's been in use for over 40 years with ultrasound guidance, so it's a well-established and integrated workflow that most of us are really familiar with. The ExactVu 29 megahertz micro-ultrasound provides a significant difference from standard frequency or lower frequency. It's real-time imaging guidance and supports biopsy with and without MRI fusion. I've been using the ExactVu system for over 8 years, and I can truly say it's made a huge difference in terms of how we evaluate and diagnose prostate cancer. Because you can use it with MRI and fusion, the fusion function is very fast to be able to be used. It's not complicated and doesn't require any type of complex contouring. And it's supported by a large body of peer-reviewed clinical evidence, which supports its use with and without MRI. The anatomical detail is very impressive, and you see here on the screen a very typical micro-ultrasound view of the prostate and the performance of the biopsy. We see tissue findings here that are consistent both with benign appearing changes as well as suspicious areas, and you can see this nicely demarcated, surrounded by arrows, hypoechoic lesion in the right apex, and it's listed as a Primus 5. Next slide, please. And speaking of Primus, if you participated in the previous webinar, you would have seen this chart of the Primus risk categories, and this clearly mirrors, and rather closely mirrors, the MRI PIRADS system. It grades tissue changes from 1 to 5 of increasing risk of harboring malignancy in the peripheral zone. We see also here a separate area of the anterior zone, which does not use the Primus categorization directly, but roughly parallels it, and is based upon high-risk hypoechogenicity patterns. Identifying these patterns does have a bit of a learning curve, but as they say, practice makes perfect. So skills develop in time, and Exact Imaging provides valuable online tutorials to aid in pattern recognition and testing your skills as you go through your process of doing biopsies. Next slide, please. So this is the procedure steps. What we do initially is perform an initial sweep through the entire prostate for orientation and alignment. And I use it also for an early assessment of potential regions of interest. Within the system, there are image presets for depth of penetration that ranges from 30 millimeter to 60 millimeter. And these will be selected by you based on prostate size and the location of the particular area that you're focusing in on. For the sweep, it's best to use a 50 or 60 millimeter setting. The next process that we do is to measure the prostate volume. And so that's performed by placing the probe in the midline parallel to the urethra. And this obtains, or through this, we're able to obtain the sagittal length. And we see in the lower picture, we see an example of obtaining the volume. We see the image on the left-hand side, the bladder neck, the apex of the prostate, and we see the calipers have been placed to obtain both the height as well as the sagittal length. The height can also be obtained on the axial view, and that's immediately to the right in the upper picture. So we use that to obtain the width of the prostate after performing a sweep. And as well as if the craniocaudal length is too large to be included on a single view. It's a nice example here that the entire prostate's on the single view, but there is a techniques to be able to stitch two images together in order to obtain the entire length. To begin the diagnostic evaluation, we place the probe in the midline, and there's an accelerometer which is set on the angle preset function, and that's set to 0 degrees. This helps maintain alignment. It permits the marking of suspicious lesions based on the angle of deflection from the midline, and it facilitates the alignment of any loaded pre-biopsy annotated MRI images for fusion if fusion is being performed. The investigation of suspicious regions is best performed separately for the peripheral zone and the transition zone, and there comes into play the primus and anterior risk grading protocols. The 30 millimeter distance is best for the peripheral zone, and depending on the prostate size, using the 40 millimeter or higher depth of penetration for transition zone and anterior prostates. For very large prostates, visualization of the apex, mid, and base peripheral zone and transition zone should be performed separately for accurate interrogation. Once we've performed this, we've identified suspicious regions of interest, we can then record the angle from the midline, which the actual degree of deflection appears on the screen. If you want additional precision, you can record the center angle of the region of interest as well as the angles at which the ROI at first and then last is visible. And we see here on the image, again, a very typical picture. This is actually midline. We see actually the beginning of the urethra through the midline. We see the seminal vesicle extending off to the left-hand side. There's a cyst here in the center from that standpoint. So the sweep here would identify lesions of concern. You'd mark that angle and be able then to refer to it as you will perform the biopsies, okay? My preference is to perform this interrogation prior to performing fusion, as it helps really to be more complete. Here we see the movement, really scanning from side to side, from lateral aspect to lateral aspect, and we can actually start then to pick up some areas of concern. So again, performing this step prior to fusion helps me to be more complete. Sort of as an internal test to me to determine if the regions of interest correlate with the MRI region of interest. And I think it's important to note that this should be performed prior to delivery of anesthesia because the fluid, the anesthetic fluid, can distort the images. When we performed the fusion through the FusionVu, the MRI overlay appears in the left upper corner of the image to allow targeted biopsies of it, whether or not there is a primus correlation. And my second case that I'll present here today, we'll see an example where the PIRADS lesion has no primus correlation. The local anesthetic technique is really per your individual technique. Needle guides are provided that have colored coded angles of 30 and 45 degrees. The 30-degree angle is really used only for anesthesia, and in fact, the bore of the needle probe actually will not admit the biopsy needle, so it's a little bit foolproof there for you. The color code for the anesthesia is white, and it actually is not only on the guide, but it also appears as the needle track on the skin. And this is really ideal for injecting at the seminal vesicle prostate angle laterally. I like to also inject at the neurovascular bundle, which can be clearly identified. You see that coming into view on the screen right now, out at the apex, and best use the 45-degree angle or the biopsy port, which is color-coded green. And delivery of anesthesia at this level, I think, is especially helpful for patient comfort when biopsying the apex, the apical horn, as well as apical transition zone lesions, and any template biopsies that are through the apex. We next perform biopsies, usually 3 to 4 cores per each site through each target lesion, and then we follow that with systematic template biopsies if they are going to be performed. Next slide. So here we see the needle guides themselves. We have 2 types. They're sterile single use, and clearly will eliminate cross-contamination risk. Each guide is pre-packaged and supports all sizes of needles. The reusable is sold non-sterile and does require processing for the initial use, is obviously between each case, as well as supports all the needle sizes for the various biopsy devices. Next slide. So let's start here with my cases. The first case I want to present to you here is a 76-year-old gentleman who had an elevated PSA of 10.5. Been a long period of time where he had no levels. There's no family history of hereditary malignancy, and his examination was suspicious for T2C disease. The MRI was performed prior to the patient being referred to me for biopsy. Volume was 30 cc's with a PSA density of 0.35, so clearly elevated and puts him at risk. The MRI showed a PIRADS 3 lesion at the right mid-apex, about 0.9 by 0.9 centimeters. And the other MRI findings were of diffuse PIRADS 2 throughout both sides of the prostate, and the radiologist felt this was most consistent with inflammation. When I performed the micro-ultrasound, I identified a primus 4 lesion in the lateral and right mid-apex, and that corresponded to the PIRADS 3 lesion that was seen on the MRI. I saw a primus 5 lesion at the right anterior apex horn, primus 5 in the right lateral mid-peripheral zone, and a primus 4 in the contralateral left lateral mid-peripheral zone. So here we see the representative picture at the right medial prostate view. We see nice arrows here that are demonstrating posteriorly the primus 4 that corresponded to the primus 3. We see this irregularity of hypoechogenicity, both more distally in the apex and a little bit more towards the mid-prostate posteriorly. And then with the calipers, you see the primus 5 up here in the anterior apical horn on the right side, which was really just described to have PIRADS 2, but this is clearly abnormal with a primus 5 lesion. Next slide, please. So this is the biopsy of the anterior horn primus 5 lesion. We see it clearly demarcated. on the micro-ultrasound. And then up in the left upper corner is the MRI overlay. And what we don't see there is any corresponding abnormality. So this is a great case where micro-ultrasound is able to identify an abnormality. Thanks, Corey, for pointing that out. We see that area on ultrasound. We don't see it on the MRI. And so here's the utility of micro-ultrasound to really identify and be able to biopsy high-risk lesions. Okay, you see the needle trajectory here on real time, so you know that you're getting a good sample of the area of concern. Okay, so very nicely seen. Next slide, please. So what do we find on pathology? For the right posterior medial apex peripheral zone, that corresponded to the PIRADS 3, was Primus 4 on my evaluation. We did find intermediate risk Gleason group 2 cancer in 3 and 3/4, but some adverse histology with intraductal pattern. In the right anterior apex horn Primus 5, again, no MRI correlate of significance. This was also a Gleason group 2 disease, 3 and 3/4, but with, again, adverse histology with cribriform glands. As I mentioned, we had some other high-risk tissue identified on the micro-ultrasound at the right mid-apex. We did find some lower-grade cancer there, Gleason group 1. In the right lateral apex peripheral zone, Primus 4. This was also Gleason group 2. In the right mid contralateral side, Primus 5, that was a lower grade 3+3. And the right lateral mid peripheral zone, very much adjacent to where of the right mid, we did find as well Gleason group 2 disease and some atypical small acinar proliferation in another site. You see here the biopsy being performed, actually static image of the right lateral Primus 5 lesion. You can see the needle track. You see an actually sort of mountain-shaped, triangular-shaped lesion, Primus 5, that the needle track is going through directly. And again, if you look at the MRI overlay, there's no corresponding change on the MRI. So again, great utility of micro-ultrasound to identify suspicious lesions and identify not only that there is disease, but the extent of the disease. And that can be very, very helpful. Next slide. So my second case here is also a patient, coincidentally, also in the same age and with a PSA 10.5. He had actually had a biopsy performed previously, which was benign several years before I got to see him. And the MRI was performed, which revealed a volume of 25.3 cubic centimeters. Again, elevated PSA density at 0.31. And the MRI identified a PIRADS 4 lesion in the lateral left mid-peripheral zone. When I performed the micro-ultrasound, however, there was no correlate with the PIRADS 4 lesion in the left mid-peripheral zone. But the micro-ultrasound reveals suspicious areas of Primus 4 and 5 in the lateral right mid-peripheral zone, the left anterior apex, and the lateral left base. And so very nicely seen here, both on real time as well as in the static image. This is the Primus 5 lesion, irregular hypoechoic, clearly separated from the rest of that. So it really stands out very nicely. And that, of course, was not identified on the MRI. Next slide. And so this is the biopsy of the PIRADS lesion in the left lateral mid. We see up in the left upper corner the MRI overlay. We actually see a little nice red dot, which is what actually shows up after you've done the marking. Thank you, Corey. There we see the area that the radiologist called, but we did not see anything on the micro-ultrasound. There is a hypoechoic area anteriorly, which is simply shadow. And these are some of the sometimes confounding variables that you can identify and see as you start to learn using a micro-ultrasound. But again, biopsy here was performed very nicely. We see that nice needle track for that. Next, you can actually also see some of the prior biopsy tracks as well. If we come back as it cycles through on the right at that view right there, there is a small little needle track that we can see at. We'll let it go one more time so you get to see that. I think it really highlights the incredible visualization and accuracy that we see with micro-ultrasound. So very nice view of that. Next slide. So this is a biopsy of the Primus 4 lateral right mid peripheral zone lesion. It's a smudgy area that we're seeing, so it makes it a Primus 4. And we see the MRI overlay, and again, there is no correlation here. So this is a finding only on ultrasound that appears to be high risk, and that we can do an accurate biopsy, and that's clearly seen as the needle traverses that site. One more time, we'll see the needle fire. Excellent. Okay, next slide. And so this is now the Primus 5 anterior apex lesion, and we can see that sort of looks almost like a bit of a bow tie up on the anterior prostate capsule, up against the capsule. That is the Primus 5. It's irregular, hypoechoic, irregular borders, as I mentioned. And while we're not seeing the MRI overlay here, there was no correlate from that standpoint. And again, we also can see these prior and previous biopsy tracks. And next slide. So what did we find on pathology? So the region of interest, the PIRADS 4 that did not have MRI, did not have micro-ultrasound correlate, was benign. The region of interest of Primus 4 in the lateral right mid peripheral zone just showed some chronic prostatitis. But the key here was the Primus 5 in the anterior left apex peripheral zone, and that was a Gleason 4+3. We see the arrows nicely showing that area, the irregularity, hypoechogenicity. Again, micro-ultrasound proved to be incredibly valuable here to identify malignancy and not miss it. Had we depended only on the MRI, we would have missed this. Next slide, please. Now, the other thing that micro-ultrasound, the ExactVu system, has an advantage is that it offers cognitive enhancement. When the MRI has been performed, but the images are not available for marking or loading, it leverages the MRI PIRADS data to create an overlay. And what we do is we input the descriptive location of the target. So if it was left base peripheral zone or right apex peripheral zone, we then align and mark the midline as well as each lateral aspect of the prostate, and it generates this diagram overlay that you see here. And then we get this nice gas gauge type or arrow indicator that as you rotate the probe, it will rotate, and so then you have alignment to the area, the location of the lesion that the MRI is identifying, and then it helps you confine your interrogation of that area with micro-ultrasound to that area, so you're not looking all the way around. So very nice alignment and providing really real-time imaging for that anatomical guidance and anatomical detail that we've already shown. Okay. Next slide. All right, so what are the benefits of ExactVu for transrectal biopsy? As I mentioned at the onset, transrectal biopsies are very familiar and have a very established track record. Yes, they are associated with a higher risk of infection, but utilization of strong mitigation strategies can reduce the risk to a very, very low level. We've adopted rectal cultures and targeted antibiotic prophylaxis, and I can say with a little bit of pride that we have not had an episode of sepsis over 5 years. So I think this really provides confidence in the safe performance of transrectal biopsies. Okay. The transrectal approach may be more suitable and possibly preferable in your practice if you have a well-established pathway, and especially given staffing and space and financial considerations. The ExactVu system can be really woven pretty seamlessly into your protocol. I perform both transrectal and transperineal biopsies as needed, and I adopted the transperineal approach relatively late in my career. But it's really the adaptability of the ExactVu system that permits its use in established transrectal pathways, but allows smooth transition or incorporation into a transperineal approach, as Dr. Meng will elaborate shortly. ExactVu can be used successfully with or without MRI. And so we do then think, well, why do we do MRI for some and not for others? And first, there's a number of issues that I have found that really affect obtaining good quality MRI images. So the imaging can be degraded by rectal gas, by bowel peristalsis, by implanted metal hardware, patient movement and breathing, and really, unfortunately, sometimes some suboptimal MRI hardware and improper sequencing. And I've seen them all. So that does make it more difficult to be able to mark. Second, patients may not be able to undergo an MRI, and that may be due to implanted devices, claustrophobia, and certainly in rural areas, there may not be easy access to obtaining an MRI. And also in my experience, the quality of the reads varies quite widely. And many times the report lacks important details for accurate identification and marking. And I've probably marked hundreds of MRIs in the time that I've been using ExactVu. And yes, I've developed some skills in being able to read them, but I still run into studies that honestly, I have no idea what the radiologist was seeing. But having that micro-ultrasound is a great confidence builder to be able to identify, target risky lesions, and not to miss suspicious areas, so we don't miss the diagnosis of prostate cancer when it's present. And I think lastly, there are some patients that I believe probably really don't need an MRI. I think digital examination is still an important tool to be able to use. And so T3 or bulky disease on DRE or having very high PSA levels really don't require an MRI to make the diagnosis. Yes, MRI can certainly be very useful and helpful to agent staging, but not truly necessary for the biopsy. So micro-ultrasound provides, and I hope I've shown this, superior visualization of the intraprostatic and really extraprostatic anatomy, making areas of concern very easily identified from that standpoint. We don't have to wait for MRI scheduling. Using digital examination PSA many times can avoid that and get the patient in their biopsy a lot more rapidly. So in summation, I think for all of these concerns and issues, transrectal biopsy still makes sense, and most especially using the ExactVu system. I think that's it.
Thank you very much. That was an excellent summary of using ExactVu for TR biopsy. And now we are going to move on to transperineal biopsy with Dr. Meng. Dr. Meng, go ahead and take it away.
All right, thank you, Dato, Dr. Dato, for that very nice introduction of TR biopsy and all the benefits of ExactVu micro-ultrasound in this setting. So I think we're going to pivot a little bit rather than show you kind of additional cases. We'll take a slightly different approach with kind of the TP portion. Next slide, please. So, what are the benefits of the transperineal approach? I do think that since the needle passes through the perineal skin into the prostate, it does avoid the rectal flora. It's been shown to have low rates of infection. It gives you improved access to the anterior and apical zones of the prostate. And often you can avoid the use of prophylactic antibiotics if necessary. There are some cons of TP approach. If the patient's awake, there's slightly more discomfort due to the perineal punctures, and especially if you hit a bony structure. If the patient's awake, it is a harder patient positioning compared to your left lateral decubitus because they're in stirrups and high lithotomy. And there's a higher risk of post-biopsy acute urinary retention, especially if it comes with anesthesia involved. Next slide, please. So why I prefer the TP approach, I usually give my patients the option whether they want anesthesia for their biopsy or if they want local. The majority of my patients elect for some sort of anesthesia when given the choice. I do think because there's less patient movement when they're asleep, it's easier for fusion, especially if you're trying to target a smaller lesion without them moving around. Allows me to have more thorough sampling of the gland because I do a lot of focal therapy here at UT Southwestern. And finally, when you're when you then come back and do a transperineal-based focal approach, such as IRE or cryo, you're using the exact same needle trajectory. So I think it makes it easier to correlate positive biopsies to where you're planning on treating later down the line. Next slide.
Go ahead.
So for our instructions, we don't do any periprocedural antibiotics. I do give them a dose of Ansef in the OR, unless certain patients have contraindications to antibiotics, such as C. diff or don't want antibiotics, then we'll do without. I do ask them to do an enema at home prior to the biopsy just to clean out the rectal vault so we don't have stool kind of in the way affecting your image quality. I do allow them to continue their baby aspirins. We ask them to hold anticoagulation like Eliquis and warfarin, and they're able to restart it within 48 hours. And we don't send anyone home with narcotics for discharge, just ibuprofen or Tylenol as needed for discharge. Next slide, please. So this is kind of my biopsy setup, and there's obviously different ways you can do TP biopsies. It can certainly be done freehand, local anesthesia. For us, I like having a stepper. We have them in a high lithotomy position. We do a scrotal sling. We shave the perineum if they're especially hairy. I have a probe stepper that attaches to the rail on the bed. And then I use the ExactVu needle guide, which I'll show you later on some of the videos, which I think is quite helpful in helping you localize your needle. Next slide, please. So this is kind of my initial setup. So these are shot through the Meta glasses. So it's not sped up, but I guess I move my head kind of quickly, so I hope I don't cause any motion sickness. But this is the patient in dorsal lithotomy. He's prepped, he's positioned. We will start with kind of putting the micro-ultrasound probe in the stepper. And this is his MRI kind of on the left side over here on the screen. You can see it's not a great quality MRI. It's pretty fuzzy, a lot of smearing. He's got what looks like an extruded BPH nodule on the right side, as well as some, maybe prostatitis on the left side as well. I'll show you kind of his lesion later. So here we start, inserting the probe into the patient. I really try to spend time to make sure I'm in midline. I do think it improves your fusion. As you can see later on when we turn on the fusion, when you go through a marked MRI, you're doing a midline sagittal slice. So here I'll take time to look for the urethra. You can see the urethra kind of on the right side of the screen. I'll then advance the probe on the stepper to make sure I can see the bladder neck, see kind of the course of the urethra all the way through. In this patient, he has a midline cystic structure, either a Mullerian duct or utricle. You can see that as a visual confirmation that we're in the correct sagittal plane as well. A few other things, this is done in the OR setting, so we have the luxury of being able to output it to an OR monitor in front of me. I think it helps ergonomically. You don't have to, turn your head to the side as you're doing your biopsy. We do use a plastic bag to cover the stepper, mainly to make it easier to clean, because when blood gets into the stepper gears, it makes it kind of quite difficult and time-consuming to clean it. Once I kind of make sure I'm in midline, I will then do a 30-second capture of the prostate in both large and small view. So this way, here this is on the slightly older version of the software, so we're hitting reset to set our angle to 0. And then as we sweep through the prostate from right to left and left to right, we can use, a few things. We can use the angle to track areas of concern. So first I'm doing a complete sweep over from the right to the left side. The angles turn negative when you're on the patient's left. And then from there, I'll hit the foot pedal, save a 30-second Cine clip. So that's large. And then we'll then go to the small view, which allows you in a really large prostate to focus on the peripheral zone. So you can see here on his small view, you can see he's got very nice Primus 1. He's got a lot of these prostatic ducts that you can see. You can see that kind of cystic appearing, well encapsulated BPH nodule there. Next slide, please. So once I do that, then I'll take my time and go through the patient's micro-ultrasound, oftentimes before even turning on fusion, right? So here we're looking at the peripheral zone. You can see he's got all these, some of them are a little bit dilated, but he's got very, very nice ductal architecture, that Swiss cheese appearance. You can see that just cystic duct that we saw earlier. You can see kind of the central zone. You can actually see the blood vessels towards the apex of the prostate with blood flow in them. So I'm pointing out stuff to the fellow I had with me in the case. So then as we kind of continue to sweep, I look at things like boundaries. What are the prostate boundaries posteriorly? Do we have any kind of potential evidence of invasion into the fat around the prostate for EPE, into the neurovascular bundles? I try to, initially do my focusing on the peripheral zone, and then we'll switch to the anterior prostate, to the transition zone assessment, to the anterior fibromuscular stroma assessment. You're looking for kind of lesions that maybe distort the boundaries of the prostate. You're looking for hypoechoic lesions. We look for things like calcium deposits, because it plays a role for certain ultrasound ablation modalities. So you can see this patient has a few periurethral prostatic calcium deposits. And sometimes this can actually confound a little bit your anterior prostate, because it can make it seem like you have hypoechoic lesions when in reality it's just a shadow. And then finally, I'll kind of look at the SVs. I'll look at the insertion of the SVs, or are there any potential, tumors or masses there? And next slide, please. So at this point, once we've kind of done a good view of the prostate, I'll turn on the fusion with my MRI. I'll go to the dual transverse screen. So we'll freeze the sagittal frame and we'll do a sweep for a digital transverse image. This allows us to then measure the size of the prostate. So you can see here we're measuring from bladder neck to apex, and then we'll measure kind of, AP and left and right. And after that, we'll then turn on, we'll basically start fusion. And one of the nice things here is fusion is quite quick compared to maybe some of the other fusion systems that you guys have experienced, where you have to segment out the prostate. All you're doing here is you're marking right and left boundaries for the MRI, for the prostate. So here we're looking at the MRI in the top left corner. We're finding where the MRI ends. Where the prostate ends on MRI rather, and then we're going and switching over it and marking where it ends on ultrasound, and then we're repeating the process on the left side. So once we have it fused, I will then, check my fusion to make sure things are correct. Is the TZ coming on is the TZ coming into the field on the MRI at the same time it is on the micro-ultrasound? We're looking for potential anatomic landmarks. So for instance, here you can look at things like, the bladder neck. You can look at cysts, midline cysts, and things like that. And one of the things to consider when you're looking at the MRI on this view on the micro-ultrasound is different from how you're used to looking at an MRI on the PAC system. On the PAC system, it's a planar sagittal slices, or 3 millimeters or whatever apart. And here it gets reconstructed as a cone to make it easier for the fusion software and a more accurate image. Next slide, please. So at this point, we're turned on the biopsy mode. It defaults to TR, so we'll switch it over to TP. And so you'll see here, when you use the TP guide, there's these markings on the screen that correlate, that goes from 0.5 all the way to 5. And it correlates with kind of the holes in the needle grid. And what I do is I'll start obtaining my targeted course first, even before local anesthetic. Reason being, when you put in local anesthetic, it does obscure your view, and it sometimes will make it a little bit harder to see the lesions, or will deform the prostate a little bit. So because they're asleep, I'll get my targeted cores first, and I'll do 3 cores per target. So you can see here he has a kind of a left sided anterior TZ mass. You can see the fusion with the highlighted circle. It's a little bit harder to see it because he's got some calcium deposits there, which obscures your view a little bit of the anterior prostate. But certainly we can see it well enough to be able to sample that area. And I'll try to put at least 1 or 2 needles through the center of the lesion, and then I may sample the edges of the lesion and things like that. Next slide, please. All right, so from here, after I do my targeted biopsies, I will then do a prostatic apex block. So here's kind of a diagram of it over here on the left side. I think somehow the reference got cut off, so I apologize for that. So I'm basically doing kind of the boundaries are kind of the levators, the edge of the prostate, the rectal hump. You can see I'm moving my needle into this prostatic apex, and I'll do 5 and 5 of lidocaine on either side, or Marcan on either side. And then at the end of the case, when I do the biopsies, I'll then come in and I'll numb up the skin and kind of soft tissues in the perineum. Next slide, please. All right, so there's multiple different templates that people use for TP biopsies. This is the music template. I use something called the modified Barzell zone, which was used for the PROMISE trial. Although in that trial, they did kind of 5 mm samples in each of these zones. So on average, they were getting 40 to 60 cores. I'm getting a 20-core systematic. I'm trying to get a slightly denser sampling for the prostate as I'm trying to, work guys up for focal therapy. We modified the Barzell zone initially to make it a little bit more efficient in the sense that you can just go down the ladder as you're doing your systematics. Next slide. All right, so here, the way it's split up is it's split up into apex and mid to base. So for large prostates, you're kind of firing in similar needle holes. For smaller prostates, I may shift my holes a little bit to try to get different areas of the prostate. So you can see here, we're doing some midline fires, my initial apex to mid and then mid to base kind of under the urethra. And sometimes you'll see I'll check my chamber as I pull it out before I swish it in the formalin. Sometimes it's just blood. If that's the case, I'll just wipe it or I'll swish it and tell the tech, hey, I'm going to get another core. Otherwise, I just do one per container. And then once I do my midline, I'll do my lateral fires. So what I'll do is using the angle on the micro-ultrasound, I'll split it into kind of thirds. So for instance, if the edge of my prostate on the right side is at 75 degrees, I'll do a parasagittal line around 25 degrees. So anteriorly, I'm sampling transition zone. Posteriorly, I'm still sampling peripheral zone. And then I'll do a medial line. So I'm trying to shift off of the edge of the transition zone to kind of focus on the kind of the lateral anterior horns of the prostate medially. And then we'll do a full lateral one. And I'll do one core, per puncture. And you can see with the way the tower works, with being able to see your needle coming in clearly, you can move quite efficiently through your systematic biopsies just by kind of going down the line. Next slide, please. So this is a sample. This is a slightly different patient, but this is kind of on the newer version of the software, you can mark out your needle cores where they were in relationship, and using the angles, they'll calculate and give you this map of your biopsy. And you can see, even though we took 32 different specimens in this patient, he had 3 MRI lesions, you're still sampling and missing quite large parts of the prostate. So I think sometimes this is a good way to kind of remind patients of how little our sampling we are doing, even though we're trying to space it out pretty nicely across the prostate. Next slide, please. So that was it for TP biopsy. I'm going to pivot a little bit to show you some additional things that I use with the micro-ultrasound. When we kind of initially approached OSC to bias the device, we said, look, we're going to use it for other things in addition to biopsy to increase the value proposition. Although they make so much money based on just biopsies alone, they're able to pay off the machine within a year. So this is just bonus for them. But we're using it for both rectal spacer placement and prostate IRE. So next slide, please. So one of the things I do is something called transurethral ultrasound ablation. I also do nanoknife, and especially for ultrasound ablation, the probe goes through the urethra. So this is a patient who's going to undergo transurethral ultrasound ablation. And for these patients, I tend to use Barrigel. I like being able to have the ability to spend time and mold the prostate. This is a patient you can see towards the apex with a posterior lesion. Very, very close proximity. It's essentially touching the rectal wall. So even though there's an endorectal cooling device, I'm worried about either damaging the rectal wall or potentially having a heat sink effect and decreasing my energy deposition posteriorly. So what I'll do is I'll go in and I'll put rectal spacer in this patient. I think this particular one is probably a Spacer versus Barrigel. And you can see what it does is it lifts up the prostate, gives me much more separation, ability to deliver energy posteriorly. Next slide, please. So a few things to remember if you're used to doing rectal spacer with a BK or something else with a dual planar probe, you don't have your transverse, you're really primarily working your sagittal plane. You do have to kind of balance your image quality versus your rectal space. Obviously, the better compression you have on the prostate, the better your image quality, but the smaller that space becomes. Because we have fusion, I can fuse the lesion. You can see here we just did the fusion really quickly. Here we have the patient has anterior or kind of left lateral tumors on the the prostate, and you can see here's that fat plane that I'm going for. So most of these patients are a little bit more challenging because the reason I'm doing it is because they have minimal spacing. So you have a very small space to go into, and the micro-ultrasound is helpful there because you can pretty clearly see the layers of the rectal wall. One of my colleagues like to describe it as the Oreo effect. So it's the, dark, white, dark there in the rectal wall. So here you can see we're coming in from the transperineal approach. I'm trying to watch my needle as I go in through that space. Or I guess here we're loading the needle. For these, I do like to hydrodissect a little bit. You don't have to with Barrigel. Barrigel is supposed to be able to lift the prostate without having to hydrodissect, but sometimes I feel like it gives me a little bit of a smoother deposit with less kind of, grapes on a vine appearance. Just pointing out the bevel to the resident with me. You want to make sure the bevel is kind of facing down as you're trying to find your way in. And the needles, unfortunately, are designed different between the companies where the color markings are the exact opposite. So here you can see I'm starting on the left side. I'm trying to do a predominantly left-sided Barrigel installation. So I'm making my puncture in the perineum. And then I'm basically advancing my needle, and I'm trying to stay right within this fat plane as I go through. And you can see here we're going right above kind of the rectal hump, trying to keep the needle in view. And then as I kind of slide in through the fat, I apologize for the contrast on this. Is a different monitor, and this is the OSC, the outpatient surgery center. So from there, once I'm in the right space, I can clearly see fat above and below the tip of my needle. I will give a little test pulse of saline to make sure. You want to see fat dissecting on both sides of you. And then from there, I'm basically pulling back the needle as I'm instilling a bit of saline just to open up that space further. I think we can go to next slide. All right, so here I'm then kind of putting on my Barrigel onto my needle. So once the Barrigel comes in, you'll see it's a different appearance versus the saline as kind of this hypoechoic, dark spot. You can see it starting to come into view here. It's nice that it's still visually transparent, the hyaluronic acid versus spacer, which really kind of blocks your view of the prostate. So, people who are doing this before, something like irreversible electroporation or something like that. Or I'll use it for my salvage cases after radiation, where I'm a little bit more concerned about, potentially infiltrating the rectum. And since we're doing this for Tulsa, I'm really trying to have a nice, smooth plane. I'm trying not to have these bubbles that kind of distort the posterior prostate anatomy. And sometimes you have to do what Dr. Garant calls the sort of zero technique, where you're using your needle tip to kind of break up these tissue planes to have a more even spacing. Next slide, please. All right, so for the last 10 minutes, I'll kind of pivot and talk a little bit about prostate IRE. So prostate IRE, for those of you who are not super familiar, it uses high voltage, low energy electric pulses. These are done through electrodes that are put through the perineum, and these are, and you run electric current back and forth between the paired electrodes. It causes permanent changes to the cell membrane. It basically forms these nanopores in the cell membrane and causes apoptosis. It's been available outside the US for probably a decade now, but it really only got FDA approval for prostate in the US in December of 2024. It had been out for, kidney and liver and pancreas, but it finally came up for prostate, so we didn't have to use it off-label. Next slide, please. This was the FDA, this was the pivotal trial in the US that led to FDA approval. It's called the PRESERVE trial, 121 patients with intermediate risk prostate cancer. Patients were allowed to have low risk cancer outside the index lesion that you were allowed to not, you were able to not treat it on trial if you wanted to. They were looking at primary endpoints of negative in-field biopsy at 1 year, which was 71%, 84% without clinically significant prostate cancer, as well as a bunch of secondary endpoints. Next slide. Not surprisingly, with focal, the urinary continence preservation and erectile, preservation are quite good. Next slide. So prostate IRE, so you can place up to 6 electrodes through the transperineal approach into the prostate. Your goal is to do about 0.8 to 2.2 centimeters of separation. So technologically, you're limited in terms of how much volume you can treat with prostate IRE. So I tend to treat more kind of quadrant or hemi-ablation. We'll then deliver kind of 90 pulses between each probe pair. This diagram kind of shows you, how you're building up your treatment zone as you're sending electricity back and forth between each probe pair. Next slide. And one of the challenges is depending on what technology you're using, if you're just using a BK, you don't have fusion. You have to try to select your treatment margins to minimize infield recurrences. And we know that sometimes MRI often underestimates the volume of disease. So our question was, can we use micro-ultrasound to help us better define the margin and with our ablation, and also being able to visualize your treatment zone after ablation can sometimes be a little bit more challenging. Next slide. So for us, we pivoted. We had the micro-ultrasound. I was using it initially with the BK. I wanted to try it with the micro-ultrasound to see if that higher resolution with the fusion helped me kind of do my IRE cases. Next slide. So this is a quick patient. I won't spend too much time on him. He's 61, was on active surveillance initially with low-risk cancer. The year following, he got upgraded to intermediate-risk cancer, predominantly on the left side. He did have one core of low-risk cancer on the right that we elected not to treat. He had, or actually, I think in this case, it was parasagittal, so I think we extended our margins over to try to capture that low-risk cancer. He had good erections, some moderate LUTs, and one of the options, so we offer kind of 3 different options here. We have TULSA, we have HIFU, we have NanoKnife or IRE. He had a lot of periurethral calcifications, and you'll see that on his ultrasound. So we elected to offer him IRE instead. Next slide. So here's his pretreatment prostate MRI. You'll see kind of 2 different markings. His predominant lesion is over here on the left anterior. He had this, area restricted diffusion on the right side that I'll mark out on the MRI, and you'll see it on micro-ultrasound as well, although biopsy really didn't show any cancer there. And then you can see on his FFP sequence, which is a special sequence we run on our diagnostic MRIs that looks for calcium deposits, he's got a pretty significant left-sided kind of PZ-TZ calcium burden. Next slide, please. Next slide. Thank you. So here, we're just doing our initial micro-ultrasound sweep, going through the prostate. You can see we've got a catheter in place showing midline. You can see some of those calcium deposits that we highlighted. Next slide. So what do we see in that initial micro-ultrasound sweep? We could see the anterior lesion. I think if you click, I'll highlight some stuff, Corey. Okay, maybe not. Go back, please. Sorry. So he's got a anterior lesion there. You can see his Foley catheter. You can see the periurethral calcium deposits. And then you can actually see some of the biopsy needle tracks that Dr. Dato was showing earlier. You could kind of see it on that side of the prostate. Next slide. So this was my initial treatment plan based on his MRI. This was his lesion, kind of left anterior. I was trying to do, a little over a centimeter margin. We were trying to capture that low-risk cancer on the parasagittal side on the right. Obviously, when you have a transrectal probe in, it distorts the prostate, so I'm replanning based on my micro-ultrasound. You can actually do this very easily without having to modify the software, just using that dual transverse view. And Brian has mentioned he's going to, eventually have some software updates that makes treatment planning a little bit more straightforward. But you can see here, this is how we're planning our needle slices and measuring our distances to program into the machine. Next slide. So one of the things that makes this possible, or makes it easier rather, so from having to freehand it, is we're using this reusable transperineal needle guide prototype that Brian and his team had developed. What this does is, unlike the plastic one we use for biopsy that limits you from the needle holes, here you can still use the needle guide to put your needle in. You can then open the needle guide and then pop your needle out. And then you can, go in and put your next needle still under guidance using the same kind of TP needle guide. Next slide, please. So here we've put our needles in. We're just doing our sweep through the prostate. So you can see using the needle guide, you have, pretty parallel ability to put your needles in parallel kind of throughout the prostate. You can see we have 5 needles in total kind of placed through the prostate. I am bracketing the urethra with IRE. I don't have, if I need to for my margin, I will treat across the urethra. It maybe marginally increases your risk of prostatic strictures, but it's not it's a very kind of low percentage of that. Next slide, please. So from there, we'll do our initial 10 pulses per pair, and then we'll adjust our voltages and our amperage to make sure we have kind of good treatment effect. So here you can see as we're treating the patient, you can actually see the hydrolysis bubbles coming off of the needles as you're starting to form your treatment zone. You can see the patient and prostate kind of pulsating. And with Fusion, you can kind of monitor. So this is kind of my room setup. We've got a nanoknife device on one side. We've got the micro-ultrasound on the other side as we're monitoring the treatment. Next slide, please. So this is our post-treatment sweep. You can see the right side of the prostate that was untreated. You can still see all the kind of prostatic structures there. And then as we kind of cross over to the left, you can see all that hydrolysis, all that treatment effect that we see. This marking over here on the MRI is the right-sided lesion. The one that is coming up is a left anterior one, and you can see that we really don't see much normal prostatic structure there, except for maybe a little bit right by the neurovascular bundle over there on the left side. Next slide. So this is his early post-procedure outcomes. At 1 month, he had some, most of these patients will have some post-procedure dysuria, urinary or urgency, incontinence. He had some nocturia. He was wearing a pad a day for safety, although really had pretty minimal leakage. He had a nice drop in his PSA at 1 month post-treatment. I saw him back at 8 months. His PSA was relatively stable. All his kind of urinary symptoms went away around 3 months post-treatment. He's pending his MRI and biopsy scheduled for later this year. For these patients, if their 1-year imaging and biopsy are negative, I'll do kind of Q6-month PSAs, annual MRIs for the next few years on surveillance after focal. Next slide. All right, so a quick summary. So, I hope what Dr. Dato and I showed you today is the flexibility of this platform. It allows you to do TR biopsies, TP biopsies. You can use it for additional treatment for focal. I think the main point is the high resolution ultrasounds, 29 megahertz, really shows you much better resolution than conventional ultrasound. You can really see things like needle tracks and tissue details that are invisible with traditional ultrasound. It's a very, very quick fusion, allows you to quickly fuse to the MRI. You can do it without MRI. For guys who can't get MRI, you can just look for lesions on your own on micro-ultrasound alone. I think it really makes me feel more confident I'm actually hitting my targets. You can tell when you're looking at your path report if you're just slightly off on fusion, you'll often pick up your lesion on systematic, but miss it on targeted. And certainly on the earlier kind of time courses, we're doing the learning curve of the technology. Sometimes you'll see that we'll miss it on target, pick it up at systematic, but that kind of disappears later on as you get more and more used to it. With the micro-ultrasound. Next slide. So a lot of supporting evidence and, the optimum randomized trial in JAMA, was kind of a landmark study on the benefits of this technology. But even before that, there were multiple different kind of retrospective and prospective kind of studies showing the benefit in comparison to MRI. But overall, we've been using this for the last few years, and it's a technology that we've greatly appreciated having. And thank you, everyone, for your time. I think Dr. Dato and I are happy to take any questions you guys may have.